Okay, myeloma bone disease is really a very common problem for myeloma. Initially, it's been reported that about 70% of patients present with myeloma bone disease at diagnosis, and in this most recent review of 500 patients almost from the Mayo Clinic, again you see about 330 of the almost 480 patients who were evaluated had myeloma bone disease, and about 40% had bone disease as their myeloma defining event. Now, myeloma bone disease is is this a pointer? Excuse me. Yeah. It's characterized by very clear punched out lesions in the bone with very little or almost no reactive new bone formation. This is a patient probably with myeloma from Newby about 200 AD, but the presentation of myeloma bone disease continues to be very similar. Now, the reason why myeloma bone disease is purely a lytic disease is that the normal bone remodeling process, as you can see here, where Osteoclast, the bone resorbing cells, remove damaged bone, and our skeleton turns over every 2 years, so it's a very active process. Then osteoblasts come to the sites of previous bone removal and fill in the gap, so that bone resorption and bone formation are very balanced processes in all of us, except as we get older where we remove more bone than we make, and we all begin to lose bone rapidly over the age of 60. Now in myeloma, the situation is really totally uncoupled, so that you have large numbers of osteoclasts actively resorbing bone and little or no osteoblast activity, so you never repair the bone. An important feature of myeloma lesions is that they almost never heal in more than 90% of the patients, regardless if you put them in long-term complete remission. So this has been a major problem for patients because their bone disease, at least the problems from them, including bone pain and fractures, once they get below the fracture threshold, persist even when they're in clinical remission. Current treatments of myeloma bone disease include osteoclast inhibition with bisphosphonates, which were really shown to revolutionize the care of myeloma patients by Jim Berenson's pivotal trial in the 90s. We do surgical procedures, vertebroplasty and balloon kyphoplasty, to help relieve bone pain and restore height, at least with balloon kyphoplasty of vertebral fractures. Radiotherapy is used to control painful lesions and post-surgery. But another major treatment that has finally become to impact bone disease is our treatment of myeloma, because our modern treatments have had a major impact on the severity of myeloma bone disease. Now, bisphosphonates, at least the ones approved for myeloma, pamidronate and zoledronic acid, are analgesic to bone. And they also minimize so-called bone-related complications, which are surgery to bone, fracture, radiation to bone, spinal cord compression syndromes, and hypercalcemia. They should be used probably in all patients with symptomatic myeloma, which we now just call myeloma, regardless if they have documented bone disease, and that's based on the Myeloma 9 trial, where 1,000 patients were randomized to either clodronate, which is a very weak bisphosphonate, or zoledronic acid. It was shown that patients, even without detectable bone disease by skeletal survey, still benefited with a survival benefit of about 5 months compared to those who got clodronate. And those who had bone disease had an even greater benefit. It's very important to remember that these agents have toxicities, such as renal dysfunction can occur and osteonecrosis of the jaw. So those are important things to remember. And because they block bone resorption, they can cause hypocalcemia in patients who are not vitamin D and calcium replete. Now, most patients with myeloma do not present with fractures. About 20% or so, and this is the review by Melton and al. In the Journal of Bone Mineral Research in 2005, present with fractures, and that hasn't really changed, as I'll show you in a minute in the other panel. But over the course of the disease, and this is an era where we didn't have consistent bisphosphonate therapy, IMiDs, or proteasome antagonists, that over the course of their disease, up to 60% of these patients will have sustained a pathologic fracture. Now, to put it in perspective, if you sustain a pathologic fracture in myeloma, your mortality is increased by 20% compared to patients without a pathologic fracture. And myeloma bone disease adds about $50,000 to the overall cost of taking care of a patient. In a recent retrospective review by Turpos of over almost 400 patients who had diagnosis, about 70% of these patients also had osteolytic bone disease, and about a quarter had skeletal-related events, and fractures were again about around 20-25%. You can see that during their first therapy, and you can see the therapy. Oops, sorry. You can see the therapies listed below. They had IMiDs and proteasome antagonists or combinations thereof. Only about 2% of the patients sustained a skeletal-related event, and even at first relapse, only 2% had sustained a second pathologic fracture, although 20% were already having bone disease. So we've changed the course of myeloma bone disease with both bisphosphonate therapy and with our better treatments. But it's still a major problem for patients because the pain persists and they still have multiple problems with their bones. Now, research in myeloma has identified why myeloma bone disease is so osteolytic. And that's because a variety of factors made by myeloma cells or induced by myeloma cells drive osteoclast formation. But the big bugaboo for myeloma is that they also make osteoblast inhibitory substances, and that is really what needs to be addressed in myeloma, developing anabolic therapies that are safe and effective in these patients. Now, one of the factors that has been targeted most recently is rank ligand, which is a potent inducer of osteoclast formation. It's a human monoclonal antibody. Denosumab is a human monoclonal antibody against rank ligand, which inhibits both formation and activation of osteoclasts. And in a trial which was examining bone metastasis in patients who didn't have breast cancer, prostate cancer, and prostate cancer, but did have lung cancer or other solid tumors, they threw in 200 myeloma patients and showed that denosumab was non-inferior to zoledronic acid in delaying the first skeletal-related event on the study. But in a subgroup analysis, they showed survival was inferior on the denosumab arm of the myeloma trial. But this was probably a reflection of the fact that none of the patients were classified based on renal function or anything else, so they weren't very well balanced. So this has led to a large 1,000-patient trial that's still ongoing, looking at denosumab versus zoledronic acid in myeloma. The other thing you should remember is that both denosumab and bisphosphonates have similar rates of osteonecrosis of the jaw, and denosumab is so potent that hypocalcemia is more frequent. Now, as I told you, those are some pretty important issues to remember, but the thing to also remember is both bisphosphonates and denosumab do not totally block the progression of myeloma bone disease, and the big problem is they don't induce new bone formation or repair lytic lesions. So patients with myeloma can have their osteoclast activity well controlled, but still never heal their lesions. So the optimum therapy for patients with myeloma is really to target the myeloma cells, the osteoclasts, and reverse osteoblast suppression. And we've most recently been trying to focus on that area to try to develop anabolics for myeloma. Now, as I told you, myeloma cells make a ton of osteoblast inhibitory factors, DKK1, sclerostin, we've shown IL-3 and TNF, and Nick Giuliani has shown IL-7 are among the soluble factors. And in addition, MIP1 alpha, which we originally identified as an osteoclast stimulatory factor, has also been shown to be an osteoblast inhibitory factor. So DKK1 and soluble frizzle-related protein 2 are really were the first inhibitors of osteoblast differentiation identified in myeloma, and that was seminal work in John Shaughnessy's group by Dr. Tian and his coworkers. And it's an inhibitor of the Wnt signaling pathway, which is absolutely required for osteoblast differentiation. It's secreted both by myeloma cells and marrow stromal cells, and they showed that marrow levels of DKK1 correlated with the extent of patient bone disease. So this has led to the development of anti-DKK1 antibodies, and Shmuel Jacoby at Arkansas has shown, at least in the SCID-U model of myeloma, that blocking DKK1 results in actually new bone formation and decreased tumor burden. If you look at the panel, let's see if I can get this thing to show. Panel over here. Okay, this is what happens in this model. This is a human fetal bone transplanted subcutaneously in a SCID mouse and then injected with primary myeloma cells from a patient. Normally, the myeloma cells chew up this bone rather rapidly in about 3 to 4 weeks. But if the animal's treated with DKK1, instead of this major loss in bone mineral density, there's actually an improvement. You see bone formation, and they have decreased tumor burden. And this has led to phase 1 and phase 2 studies of BHQ-880, which is an anti-DKK1 human monoclonal antibody, and relapsed refractory myeloma patients who were also receiving anti-myeloma therapy and zoledronic acid. The anti-myeloma therapy was MPT, and it was mostly done in the Soviet Union. And the results of that study were very hard to interpret. There is a phase 2 study that has just been completed in patients with myeloma to see whether it can build bone and decrease tumor burden, but I am not aware yet that those results are available. Raji's group was the first to really look at Activin A in myeloma. Activin A is a bifunctional cytokine, at least for bone disease. It's a major stimulator of osteoclast formation, but also inhibits osteoblast differentiation. And Rebecca Silverman in our group has looked at the role of Activin A in IL-3-induced osteoclastogenesis. IL-3 is also another bifunctional cytokine produced by myeloma cells and T cells in the myeloma microenvironment. There's a potent inducer of osteoclasts, but also, as Raji showed, induces Activin A and blocks osteoblast differentiation. And what Rebecca showed is that IL-3 really can induce osteoclast formation in vivo in a mouse model, and that anti-Activin A blocks that osteoclastogenesis, and this has led to an ongoing phase 2 trial at our institution looking at Sotatercept, an Activin A receptor antagonist, effects on bone mass and turnover in patients with myeloma who are in CR and are in stable disease for at least 2 years. And this Activin A receptor antagonist, the rodent form, has been used by Peter Croucher's group in the 5T2 model of myeloma, and you can see that normally these myeloma cells chew up the bone dramatically, but treating them with this Activin A receptor antagonist both blocks bone destruction, stimulates bone formation, and decreases tumor burden. There's been one phase 2A trial of Sotatercept in patients with myeloma that was reported in the British Journal of Hematology recently, and it had modest effects on bone alkaline phosphatase in the cohorts that were studied, and there was really no dose-dependent effects, but there were some signals to suggest it might be active, and this is going to be pursued. But the real question is, what is the mechanism for long-term osteoblast suppression in myeloma? I told you the myeloma bone lesions don't heal even if you get rid of the myeloma, and for clinicians, the best example to think about is a solitary plasmacytoma of vertebral body. You can cure those patients with radiation therapy in about 30% of the time, but their lesions persist for the rest of their life. So we became very interested in trying to understand this phenomenon in order to repair myeloma bone. And just to put it in perspective, if you take osteoblast precursors from mice injected with a murine myeloma cell line 5T-GM1, they will not differentiate even if you passage those cells for months. Thus, they are able to form other types of mesenchymal stromal cell-derived products like cartilage, and they can form fat cells, but they will not differentiate, and that's because in contrast to normal osteoblast precursors, that they do not express very high levels of the key osteoblast transcription factor, RUNX2. So we became interested in trying to test the hypothesis that epigenetic changes in the RUNX2 promoter may explain long-term suppression of myeloma bone disease, and we did promoter studies on the RUNX2 promoter and identified GFI1 as a putative factor inducing epigenetic changes in osteoblast precursors, which would produce long-term inhibition of osteoblast differentiation. Now, GFI1 is a transcriptional repressor that recruits histone-modifying enzymes and co-repressors to target genes, and in particular, it brings HDACs to the promoter as well as co-repressors, and it can modify chromatin structure, so we thought it was a good candidate. And we found that in marrow stromal cells from patients with myeloma, we've looked at about a dozen or more now. This was the initial publication back in 2011. All marrow stromal cells from patients with myeloma bone disease express significantly elevated levels of GFI1, which you can see here compared to the normal bone marrow stromal cells. More importantly, if you knock down GFI1 in these marrow stromal cells from patients, as you can see here, you get increased amounts of RUNX2 being made, increased osteocalcin, increased bone sallow protein, and you get osteoblast differentiation. Importantly, HDAC inhibitors will block the effects of GFI1 on osteoblast differentiation and suggest that although we've heard a debate about HDAC inhibitors, targeting HDAC1 may be a reasonable way to try to block the effects of GFI1, and we're currently testing that hypothesis in a mouse model of myeloma. Finally, there's another way to maybe target the bone destruction in myeloma, and that is taking advantage of what we know about adhesive interactions between myeloma cells and marrow stromal cells. When myeloma cells bind marrow stromal cells, they induce growth of myeloma cells and they make them chemo-resistant. They enhance osteoclastogenesis, and they also suppress osteoblast differentiation. Now, multiple signaling pathways are activated in marrow stromal cells when myeloma cells bind them, but a lot of them go through the signaling platform called P62 or sequestosome 1, which also has a role in autophagy as well as other processes. And it's composed of 6 domains, the SH2, PB1, ZZ, P38, TBS, and a ubiquitin binding domain that serves as signaling platforms for various cytokines and factors, like IL-1, rank ligand go through the TRAF6 domain, TNF goes through the RIP1 domain, etc. Now, we made deletion constructs of P62 and transfected them into P62 knockout stromal cells and found that the ZZ domain played a major role in support of myeloma growth and osteoclastogenesis. And using some very sophisticated techniques in collaboration with co-workers at the University of Pittsburgh, Dr. Shee's group, who's a medicinal chemist, we identified a small molecular inhibitor of the ZZ domain of P62. And in vitro, it will kill myeloma cells, it blocks osteoclast formation, it has no effect on hematopoietic cell growth or stromal cell growth. It does decrease VCAM1 binding, which binds myeloma cells to stromal cells. It blocks IL-6 production, NF-kappa B signaling, and because it's the ZZ domain and not the P38 domain, it doesn't affect P38 signaling. So Rebecca and Dr. Teramachi did this recently reported in vivo experiment in leukemia. We have a model where we inject labeled 5T-GM1 cells into mouse tibia in a immunocompetent syngeneic model. We waited till the disease was established at 2 weeks and then either treated these animals with our ZZ small molecule antagonist or vehicle, looked at toxicity, PK, IgG2B levels, which is the monoclonal protein made by the 5T-GM1 cells, and evaluated their bone disease and tumor burden. And what we found was that this ZZ antagonist caused dramatic new bone formation only in myeloma-bearing bones. So it's not a stimulator of normal osteoblast differentiation, because if you took the contralateral tibia from these mice, they're only injected on one side, there's no effect. And this is what you would have expected if you just had the tumor present and treated with vehicle, which is lots of lytic lesions, and here you have dramatic new bone formation. to let you see what we're talking about, this is myeloma in the bone of these animals. And you can see the marked increase of new bone formation. It's rapidly delayed down, so it's not laminar bone. And you can see that osteoclasts are actually remodeling these bones. So we think we blocked the uncoupled relationship between osteoclasts and osteoblasts and myeloma. Finally, I'll close with reminding you that a number of the agents that we use also have effects on bones, such as Bortezomib and Lenalidomide. Bortezomib and proteasome antagonists have been shown for a long time to act on marrow stromal cells and osteoblast precursors to enhance RUNX2 production and increase osteoblastogenesis, as well as block osteoclast formation. And that may explain, in part, why patients who get Bortezomib will have an increase in their alk-phos, at least transiently, when they're initially treated. And Suzanne Lynch has shown nicely that lenalidomide blocks osteoblast precursor differentiation and takes them down the granulocytic pathway rather than the osteoclast pathway. So we have a number of novel targets to try to change the sad outcome of patients with myeloma bone disease. We have Denosumab. For MIP-1 alpha, we have the CCR1 receptor antagonist that should be going into clinical trial. We have anti-DKK1 antibodies, and Bortezomib lowers DKK1 levels. We have the Activin A receptor antagonist that is in clinical trial. There are anti-sclerostin antibodies in trial for osteoporosis that look good and may go into trial for myeloma fairly soon. And I would suggest, and we're testing whether HDAC1 inhibitors may be able to reverse the prolonged suppression of myeloma. This slide acknowledges all the people who've worked on these projects over the last 10 years. We've been funded both by the VA, the MMRF, and the NIH for these studies. I thank you for your attention and would be happy to answer any questions if we have time.